for joining me today. In this video, I want to go over with schizophrenia. I want to go over the integrated care considering in management of schizophrenia. We'll describe the relationship between schizophrenia, antipsychotic therapy, increased risk for cardiac risks and metabolic diseases. I will describe the relationship between schizophrenia and psychotherapy, identify the evidence-based monoparamerics like weight, diabetic, liver balance. I will go over the required for the patient to receive an antipsychiatric medication, identify the evidence-based monitoring. I will explain the impact of a smoke, substance use disorder, suicidal risk to monitor, obesity, morbidity, and mortality in the individuals with schizophrenia. Assessment you have to do for cardiac, metabolic, suicidal, substance abuse risks using the validated screening tools in patients with schizophrenia, in how to interpret the labs, clinical findings to evidence emergency cardiac complications. I have schizophrenia and clinical overview. Schizophrenia is a chronic, severe psychiatric disorder characterized by disruptancy in a thought, perception. It affects the thought, perception, emotion, behavior, and resulting in a significant functional impairment. Managing schizophrenia across the setting include inpatient unit, outpatient clinic, community mental health, integrated primary care environment. Schizophrenia life prevalence is 0.3 to 0.7 percentage. That is how prevalent it is. Onset male is late teens to early 20s. So it shows up early teens and late 20s to early teens and late 20s. Late teens to early 20s. Female is late 20s to early 30s. That's when the schizophrenia symptoms shows up. And course is episodic, chronic, with residue symptoms. Schizophrenia carries high mortality, increase mortality, and high morbidity. Substance abuse risk for comorbidity and conditions such as substance usage disorder, cardiac risk, and suicidal ideation. Those are what those are what affect a person's life. Those like the substance abuse, cardiac diseases, suicidal ideations are the what carries the morbidity and mortalities. Neurodevelopmental risks for schizophrenia. Schizophrenia is best conceptualized using the biopsychosocial and neurodevelopmental framework. Schizophrenia is hereditary, estimated 70% of 70% to 80%. So 70% to 80% of schizophrenia is hereditary. You get from your family. It has a multiple genes, risky involved genes related to dopamine signaling, synaptic plasticity, immune regulation, neuroinflammation. Those are the risk factors of developing schizophrenia. Neurodevelopmental disruptions during the prenatal or early life period relate to alternate brain changes. Clinical impacts include the gene risks information, early identification, and family psychoeducation. So the clinical implications include genetical risk informs early identification and family psychoeducation. Neurotransmitter dysregulation. There is a neurotransmitter dysregulation that involved in schizophrenia, and they include mesolenic hyperdomigation that leads to positive symptoms, and mesocortical hypodopaminergic that leads to negative symptoms and cognitive symptoms. So if the dopamine is more, it leads to positive symptoms of schizophrenia. If the dopamine is less, it leads to negative symptoms and cognitive symptoms. Other implications include glutamate receptors of hypofunctioning. So glutamate is functioning less than normal, that link to cognitive deficit. GABA dysfunction is also linked to impaired inhibitor control. Serotonin serotonin is linked to rational for atypical anti antipsychiatrics. So those are the neurotransmitter dysfunction related to schizophrenia. Functional abnormality. Functional abnormalities include neuroimaging study demonstrated and ventricle enlargement, reduction of a cortical gray matter. Those are the abnormality found in the brain of person with schizophrenia. Disruption of a frontal and temporal connections was also found. This functional These findings support schizophrenia as a disorder of a brain circuit, not character or willpower. Psychosocial contributories include obstruct complications like hypoxia, prenatal infection or malnourishment, childhood trauma can lead to schizophrenia. One of the risks are childhood living in a urban living, immigration, social exclusion. All this stress and trauma can lead to schizophrenia in adult life. Cannabis use during the teenager years is dose dependent, has a dose dependent risk attached to that. Stress diethyris model, biological vulnerability combined with environmental stress precipitates the symptoms onset and relapse. An essential framework for relapse prevention planning. So Maral thesis Maral says that biological vulnerability combined with environmental stress factors precipitates the symptoms onset and relapse. An essential framework for relapse prevention planning. Clinical presentation of a schizophrenia include positive symptoms. Positive symptoms include delusion of persecutories, referential grandiolous hallucination, primarily auditory and visual, disorganized speech and thinking, loose association, tangential, grossly disorganized or charactonia behavior. Those, as, those are positive symptoms of a schizophrenia. Negative symptoms of a schizophrenia include affective, flat effectiveness, elogia, alleviation, sadness, social withdrawal. Providers emphasize a negative symptoms respond poorly to medication. So if the patient has negative symptoms, they poorly respond to the medication, significantly impact the functional and recovery. So patient who has a negative symptoms, they have a hard for recovery. Patient who have a significant impairment have a hard time recovery. Diagnosis. The key diagnosis requires greater than two core symptoms present for more than 1 month. What are the core symptoms? The core symptoms are the hallucination, delusion, negative symptoms such as withdrawal, delusional, disorganized thought and speech. Those are the core symptoms, and they have to be present in more than 1 month. And patient has to have a functional decline and continue illness more than 6 months, 6 months or greater. Exclusion of mood, then as a provider, you will try to exclude if this is mood disorder with with psychotic figures and substance induced psychosis or medical causes. So you first will exclude and see if this is not mood disorder, this one is not substance induced psychosis, this one is medical cause disorder. So if you rule out all this and you have all these characteristics, that is when you diagnosed with that's when you diagnose the patient with schizophrenia. You have more than two core symptoms present that been with the patient 1 month or more. Patient or the person has a decline, functional decline. They continue being ill more than six months or more than, and they don't have mood, and this is not a mood disorder. This illness is not substance induced psychosis, and this illness is not medically causes. Then that is when you diagnose as a schizophrenia. Comprehensive evaluation include assessment, and assessment include full psychiatric history and mental status examination, collaborate information like the family, caregivers, you talk to the person's family, other caregivers, you assess substance use, you rule out if they are having or these symptoms is caused by substance abuse. You also medically evaluate their CBC, CMP, thyroid, urine toxicity, so you can rule out if there is other causes for these symptoms than schizophrenia. You do neuroimaging if the first episode or a typical present. Differential diagnosis include bipolar disorder with schizophrenia features, major depression disorder with schizophrenia disorders, psychoaffective disorder, delusional disorder, substance-induced psychosis, neurocognitive disorder. Those are the differential diagnoses that mimic schizophrenia. So you have to rule out this first, and then you can know this is schizophrenia. Treatment plan is a center approach. Treatment is a lifelong So schizophrenia treatment is a lifelong, is individualized. So it's not applied to everyone. Every person is unique. So you will make it the treatment individualized. And you collaborate with the family, with the person, with other providers. Pharmacology management include there is a pharmacology management and therapy management. For pharmacology, first line of treatment is the antipsychiatric medication. Second generation atypical antipsychiatric medication are the first line of treatment. They include Risperdal, olanzapine, Seroquel, aripiprazole, peptidone. Advance advantage is they have reduced EBS risks. Second generation has a less EBS risk than the first generation. That's why second generation atypical psychiatric is the first line of treatment, and they are preferable because they have a less EBS symptoms, side effects. Some benefit for negative symptoms, so they also improve the negative symptoms so the patient can function normally. Risks to manage is the metabolic syndrome. However, second generation, they increase the risk of weight gain. They increase the person appetite. You will be craving for carbohydrate. Person will be craving for carbohydrate, so that will increase their weight. It will increase their lipid. It will increase the risk for diabetic. So you will assess the weight, lipid, and diabetic risks. Treatment resistant schizophrenia. Treatment resistant schizophrenia is defined as an inadequate response to two or more antipsychiatric trials. Clonazepam is a gold standard for treatment-resistant schizophrenia. It requires RAMS monitoring. Risks include agonocytosis, cardiac inflammation, myocardial inflammation, and seizure. Those are the risks of clozapine. You can use long-term acting injections, antipsychiatric medication if the patient is not taking their medication and they are not adhesive to their medicine. This injection is improve the adhesiveness because the patient will take only twice a month. It will this medication is, which is the long-acting injection antipsychiatric medication is, they reduce the relapse and re-hospitalization or hospitalization. They can remain outpatient. They are essential tool in practice. Evidence-based indication is for long-term injection use. Long-term active injection use strategy reframes use is a last resource to a early proactive interventions. So they are the last resource if the patient is using their medication and they are following the treatment plan and you can control their symptoms without using this, you shouldn't be using that. But they are the last resource. First episode psychosis to improve the long-term trajectory. Partial or inconsistent oral adhesiveness. That's the reason you use long acting injections. If they are not consistent with taking their oral medication, if they are high relapse or have a hospitalization risks, co-occurrent substance use disorders, they also have a substance usage disorders. They are cognitive impairment or poor insight. They have a cognitive impairment. They cannot follow the treatment plan. They cannot take their medication. They cannot seek treatment when they are sick. So long-term injections will help with them because you will have an appointment. They will come twice a week, twice a month. So it will improve the treatment plan if they have to be. Justice involve Justins in involve populations if the court ordered that. Also they be used. Limited access for pharmacy service. Some people have limited access for getting their medication. Early long-acting initiation is associated with reduction relapse and improve functional outcomes compared to delay implementation. So there is a benefit to the long-acting injections of psychiatric medications. Long-acting injectionable psychiatric medications are listed here. Their names are here. How long those interventions are here. The key consideration is to use it here. So Haldol has EBS risks and cost effective. Raspadol you choose over lab requirements. Those are the key considerations when you are choosing one medication over the other. Psychotherapy interventions include cognitive behavior therapy for psychosis, psychoeducation for the patient and the family, social skills training. You want to provide that to the patient with the medication. With the medication, you will provide cognitive behavior therapy for psychosis. You will provide psychoeducation for both the family and the patient. You will provide social skill training. You will support employment and education. A seraph community therapy. You will use a seraph community treatment therapy. Clinical interventions include collaboration with primary care to ensure the routine cardiovascular screening is being done, monitor antipsychiatric with lower you will use the antipsychiatric medication with low cardiometabolic risks when clinically appropriate. You will consult the patient using the motivational interviewing instead of direct education. You will advocate for integrated primary care, behavior health, models, clinical behavioral. You will address the cardiac vascular risk early, improves antipsychiatric adherence, and reduce long-term hospitalization. Long-term outcome long-term outcomes is approximately 20 to 30 achieve significant recovery mostly. Many experience persistent symptoms with varying disability, prognostic indications. Favorable factors include late onset, good pre-morbid functioning, strong support symptoms, early and sustained treatment. Poor prognostic indications include early onset, med negative symptoms, as we mentioned before, cognitive impairment is one of the negative prognosis. Substance usage, poor medication adherence. If the patient don't take their medication, that will lead to poor prognosis and recovery. Recovery-oriented outcomes include recovery is defined not solely by symptom reduction, but functional independent. Is the patient independent? Do they have a meaningful role? Do their quality of life improved? Do they have self-determination? So those are recovery that you will look for. For summary, understanding schizophrenia, diagnosis clarification, we go over the diagnosis clarification, we go over schizophrenia, we describe the medication that you will prescribe and monitoring the antipsychiatric risks. We go over managing side effects, coordination, interdisciplinary care. You will coordinate with others, with the family, with the social worker, with outpatient treatment. You will coordinate that. You will provide psychoeducation to the family and to the patient, as we mentioned before. You will advocate for recovery-oriented and stigma-free care. Thank you for joining me today. I would love to see you in my next video. Take care.